As apropos that last video you just saw, we're channeling into the clinical implementation of immunotherapy. And this is such an exciting moment to be in the country at this point in time, coming together to talk about how do you do these things across the system with the people that you just heard on our board. You have legal, you have outreach, you have the community support. We're also now going to transition much more into the clinical implementation and how we make the decisions about outpatient, inpatient, actual care of the patient. So I want to start by introducing our panelists. Our first one is Karen Anderson, and as you know, she is the manager of the Bezos Family Immunotherapy Clinic at Seattle Cancer Care Alliance. She was involved with the design and planning and opening of the clinic in October 2016 and has helped support the program in all of its development. Her experience includes roles as a BMT staff and research nurse, a clinical oncology nurse specialist prior to launching this immunotherapy clinic. She became a nurse in 2004, earned her master's from the University of Washington in 2009. Her interests include infusion therapy, nursing professional development, and nursing research. She's passionate about helping nurses understand cellular therapies to support patients in getting their best possible outcomes. It was Dr. McDonald and Karen's idea to start this journey of adventure. So we're very lucky to have this conference because of what Dr. McDonald and she had together. Our next panelist is Colette Chaney, who comes to us from the Fred Hutchinson Cancer Research Center, where she has worked as a clinical research nurse for 13 years, and she's currently serving as the Immunology Program's Clinical Research Operations Manager. Colette has dedicated her entire career to the care of oncology patients. She began at Johns Hopkins as a pediatric bone marrow transplant nurse, then took that skill on the road as a traveling nurse in some of the major cancer centers in the nation. She has worked as an inpatient oncology nurse, adult nurse, the oncology case manager, a hospice nurse, and an assistant clinical nurse manager before she came to the Fred Hutch. Colette received her degree, her bachelor's degree of science and nursing from, this is the East Coast School, Towson State University in Maryland, and has an oncology nursing certification. We have next Angela Kirk. And Angela is a PA, a physician's assistant in our immunotherapy program. She's been working as a physician's assistant specializing in hematologic disease since 2001. She began her career in hematology, oncology, and stem cell transplant in Dallas, Texas at UT Southwestern Medical Center's Simmons Cancer Center. In 2011, she moved to Seattle and began working at Fred Hutchinson Cancer Research Center at SCCA. She transitioned from the transplant department to help open and staff the new Bezos Family Immunotherapy Clinic at SCCA in the fall of 2016. Next, we have Lindsay, who you've already met, but Lindsay has been a nurse for over 20 years in the fields of oncology, bone marrow transplant, apheresis, 18 years of experience in apheresis, and 4 in the medical industry, medical device industry, providing customer technical support and service training. She has built FDA and FACT-compliant apheresis program, implemented a healthy donor collection facility, and authored 4 abstracts, and developed training and competency programs, implemented pediatric photopheresis program. Lindsay is currently the nurse manager of a 6-bed, 16-nurse apheresis unit at SCCA, and a subject matter expert consultant. And do you guys remember what else she is? She loves peanut butter and marshmallows.
Peanut butter today, so I'm...
Peanut butter today, good. Next we have Reese, BSN OCN. She's the professional practice coordinator and the Bezos Family Immunotherapy Clinic, and is the professional practice coordinator within the immunotherapy clinic. She's earned her bachelor's degree of science from the University of Washington. She's been a nurse for over 18 years with experience in inpatient and outpatient settings with bone marrow transplant and general oncology. She joined the immunotherapy clinic in 2016 to develop and launch the program in the immunotherapy clinic, and is passionate about supporting best nursing best nursing practice, education. So we're going to begin, as the video would suggest, with questions that really focus now from implementation and logistics to what are the clinical components of this. So for the first question, I'm going to send these first to Karen and Lindsay. What are the services that nurses and care leaders need to work with to really get therapy off the ground clinically? Karen, do you want to start?
Yes, Anne, can you hand me the slide advancer? Thank you. Do you mind repeating the question?
Yes. So the question is, what are the services that nurses and care leaders need to work to get into this therapy and have this successfully get off the ground?
Okay. Well, I think a lot of it is dependent upon the facility and the infrastructure that you already have in place. So at the Seattle Cancer Care Alliance, we've had a robust outpatient transplant program for more than 2 decades, I believe. That was really a foundation in which we started providing these therapies. When I came to the clinic, as Jeff already mentioned, we had essentially 2 trials that were open and kind of running out of the transplant clinic, and 1 that was running out of the general oncology clinic. And so we'd already had some experience at that point with CAR T cells. We initially started CAR T cells in the inpatient environment, and Colette can certainly speak to that because she was the clinical research nurse on those trials. But after some time and some experience and really an assessment of the toxicity profiles and the onset and management of those, we moved the infusions to the outpatient. And so when I came to this role, outpatient infusions of CAR T cells had been going on for some time. But we had experience with that particular product. So when we thought about what we needed in place to be able to do inpatient or outpatient, and we really thought about, well, what does a patient need from a safety perspective? So, and who are they going to need to access, where are they going to need to access care? So transplant has the same sorts of similar issues in that patients can get septic, they need 24-hour triage, and that is the same for cellular immunotherapy patients. We were able to do the infusions. We send patients home. They get a lot of instruction about who they should contact, where they should contact, and what those phone numbers are 24/7. Other things that we did, because again, we feel like they're important for patient safety, are the requirement that patients live close to the center. So you've already heard that we have a requirement of that patients generally stay within about 30 minutes of the center when they're getting CAR T cells. We also give them our own program wallet cards. So in addition to the now FDA required wallet cards for the 2 commercial products, they get one the minute they walk in the door that has 24-hour triage numbers that if they were to land in the ER, really from the point that we meet them, they could present to the ER providers that would immediately get them access to a care provider that has some understanding of what therapy or what program they're associated with. So those were 2 things that we really just adapted from our bone marrow transplant program because they worked very well for this population. They stay close, we give them wallet cards, and the last piece is that we do require caregivers for a portion of the time that we are administering CAR Ts. So really from the time that we start lymphodepleting chemotherapy through roughly a month after the therapy, we like for them to have an identified caregiver, and we feel that's really important. High fevers can come on rapidly, neurotoxicity can occur, and we need to make sure that a patient can access the care that they need very quickly. So we invite caregivers, certainly, and many of them have caregivers from the minute they walk in the door or through the entire process, but if they're not physically there, then we do have the ability to teleconference people in. We create extra education visits so that people that have rotating caregivers can really access the team and the education if they don't have a caregiver who can necessarily be there for 2 solid months. So we try to make it work depending upon the patient's situation, but we do really emphasize the need to have somebody with them. So I think those are the 3 things that we have in place infrastructure-wise that have really allowed us to move things to the outpatient department. And then we take a really critical lens and eye when we're doing implementation of new trials and new products to look at the toxicity profiles. So we actively are sitting down with our medical directors and everybody else on the team to say, you know, if CRS is going to onset within X amount of time, how much, does this make sense for us to be doing in the inpatient or the outpatient department? So we are actually really involved in having active discussions about that. But our bias is to try to do things in the outpatient as much as we feel is safe because we think patients like that.
So Lindsay, could you talk about what it meant to have the program begin in apheresis and what needs to be in place for that kind of work?
Sure. So There's nothing that's dramatically different for collecting an immunotherapy product in apheresis versus collecting a standard of care hematopoietic progenitor cell product or mononuclear cell product for standard of care. It's the same cell that we're looking for many other procedures. The operations will be slightly different in terms of the care coordination and in terms of managing the product post-collection and the variables for the manufacturer that they're requesting for that product to be collected. However, the patient's experience will feel the same to them as any other product that we're collecting. So operations that are set up for apheresis for standard of care really shouldn't be significantly different or even very much different at all for immunotherapy products, whether they're marketed or whether they're a clinical trial. What will feel different on the back end is for the staff to have the resources for that care coordination. And when I gave a presentation yesterday, I was speaking specifically to a job aid that we use that helps us really understand all the variability that's specific to all the different clinical trials that we do or the marketed products that we collect. And that helps the nurse operator doing the collection prevent any deviations so that they can stay on target with those different details. But operationally, the collection of the product will be the same, whether I'm doing a mononuclear cell collection for a Kite product or a Juno product or a Novartis product or a clinical trial that is still an IND. One thing that is important, however, to be attentive to, whether it's standard of care, but specifically for immunotherapy, is that these patients will be on the spectrum of clinical status, maybe a little sicker sometimes than your standard of care patients. And in that regard, you may expect that there will be maybe more inpatient collections than you're used to. So we do predominantly outpatient collections in our outpatient facility, and we're set up for that in our outpatient facility. But we also do inpatient collections as well, and we're not attached to our inpatient site. So we travel to that inpatient site, and we have operations already set up for that. But if you're at an institution that does not have that capability, then that's something that operationally you'll have to be looking at, how to set up that infrastructure to travel to the inpatient location. And I was having a discussion with somebody this morning regarding a marketed product pushback on where those collections can occur. So if within your program you know that apheresis collections will be occurring inpatient and outpatient, then as part of the initial site initiation visit or the pre-study visit, the auditing should include taking the auditors to every location where your apheresis operations will occur. It's unfortunate to hear that there might be a sponsor that will dictate where that collection should be occurring, and that's not appropriate. The appropriate thing is for the institution to say it's safest for the collection to occur in these locations that we've already designated, and then to tell the sponsor this is where it will be happening. So that's something that I think is very important to take a very proactive and firm stance on. But again, we're already set up to do outpatient and inpatient collections, so for us that was not operationally different.
Catherine, can I?
Well, I was going to say, I'd like for Colette to speak to this on the side of research and clinical trials and what those transition pieces are.
Before that, just the infrastructure that I found very helpful to have in place was that of a dedicated, well-educated group of providers. So we have dedicated APPs, we have dedicated attending physicians, nurses, schedulers, and all of these people were imperative to providing good quality care to this patient population. And then what was the second part of that?
In terms of research protocols, with so many protocols coming down, you know, whether they're commercially sponsored or the investigators at a center, what are the things that you see that are important for FDA readiness for the implementation and infrastructure for those living, as Helen called it yesterday, living product collection?
A well thought out implementation plan with structure, training, We do standing orders that direct the care of these patients. We provide scheduling guidelines. We do educational in-services for staff. We work directly with infusing nurses to ensure that they have the adequate skill sets. We talk about toxicity profiles. So any new study that comes into the clinic has an implementation meeting, kind of like a site initiation visit, where we evaluate each of these elements.
Thank you, Colette. Angela, can you speak to what it's like to manage the care from the point of collection throughout the process once a patient enters the immunotherapy program?
Sure. So I have experience in both transplant as well as now in immunotherapy, and certainly managing the immunotherapy patients are similar to transplant or hematology oncology patients. The difference is, as Lindsay pointed out, that these patients are potentially sicker. They certainly do have active disease. In transplant, you're often managing patients who are in remission or have very minimal disease. And so this is a patient population that has not responded appropriately to the previous therapies given. They have a burden of disease that's sometimes rapidly progressing. So it has been it's just a real big point to recognize that from the very beginning, when you're seeing these patients and educating them on the process of CAR T cells or immunotherapy, that they're actively progressing. So the timelines that was talked about in the previous panel is very important. There's often bridging therapy that needs to be handled just to keep the patients kind of in a good field to be able to proceed forward with the CAR T cells. And that can sometimes be done through our institution or through a referring physician. I find sometimes it's easier to keep the patient in our own system so that we have your hands on them and know exactly when the best time to proceed with a therapy or with the CAR T cells are, and that they don't go away and then come back and look really sick as if you can't proceed right away. So there is certainly a lot of managing of the patient up front, just getting them to that process. And then we are pretty well established in doing the CAR T cell infusions here at SCCA as an outpatient. We were fortunate that many of our clinical trials were of a product that didn't seem to have CRS quite as an abrupt onset as some of the other products. And so we found by initially doing them in the hospital and then watching and seeing the timeline of CRS that we could facilitate them in an outpatient clinic. And then we monitor them very closely. And that's where I'd say it's very similar to a transplant patient, that we see these patients daily for a given time. Even though labs may be not exceptionally low, they've not received this myeloablative therapy, they're kind of receiving a standard dose therapy, but just having eyes on them, seeing them every single day, and being able to tell when things require an inpatient stay and getting them there when that's necessary.
Thank you, Angela. Anne, in thinking about what we've just been speaking about, getting nurses ready for this, can you speak to some of that training?
Yeah, so our nurses receive a lot of information, trying to keep them up to date with all of the changes that are going on in the field. So our nurses initially start with some overarching immunotherapy principles and practices. How do we manage CRS? What are we looking for? What are the time frames? And then the information progresses from there. So we have a lot of clinical trials in our group. So each of our clinical trials that comes into the group, our nurses and all of their staff sit down and do a protocol overview. So they get taught about why are we doing this therapy, and it's always a great review for our nurses for what are we looking at? Why are we looking at a clinical trial that's changing some of the modality? What are we looking for? And what are the new things we're learning for treatment of these side effects? So our nurses get overarching information, protocol-specific in-services, which can be approximately monthly, and then the nurses get infusion-based trainings dependent on the product itself and what the requirements would be for infusions.
Thank you. Karen, can you speak to how the design of the unit really fed into how you would create the clusters of care and that education with the daily huddles for your nurses?
I do have a slide that I put up, and this is really kind of a schematic of our model of care. From the clinic perspective, we try to bring everything to the patient as much as possible, and you'll see this for those of you that are doing the tour. We really try to consolidate the care in one location, so we can provide lab draws, we provide infusions, and we provide the clinics all in one clinic, hopefully even in the same room. So ideally, the patient comes into the clinic, and then services kind of come to them. The model for this was really based on trying to minimize patient waits, and improving the patient experience of receiving care, but we also do believe that by bringing everything together in close proximity, and I can tell you from the number of emails that I get a day, that certainly the closer you are and the easier that communication flow in a land that's changing as quickly as cellular immunotherapy, that close proximity truthfully has been such a benefit to our design. So we have morning huddles. We talk about what are the expected infusions for that day, anything that we need a heads up on, so highly reactive agents, brand new first infusion, anything that we want people to kind of know is happening for the first time. That's the start of our day. We also really thought about in the design of the clinic, what are the patient services that they were going to need and how long those were going to be needed for. So that kind of influenced the model of care. So we're actually open from 8 in the morning until 8 p.m. at night. We have cellular products that show up in the late afternoon, and then we need to perform post-infusion monitoring. So that's one of the things that we really looked at before we designed the clinic, and then as we look at new trials that are coming in, we're very thoughtful about how that's going to play in. If there are PKs, anything like that, you know, we need to know and plan for how we're going to do that. But ideally, we want everything to happen in the clinic just because it just works better. There's fewer opportunities for error if you have things kind of happening with one group that really knows all of these clinical trials. So obviously patients still need care 7 days a week. So I said Monday through Friday, 8 a.m. to 8 p.m. But we do work very closely with our bone marrow transplant, which is open 7 days a week, and we staff a nurse in our bone marrow transplant clinic to see our patients on the weekend. She's actually here. So we have one primary nurse on the weekends, and so she's really that piece of continuity through the whole 7 days a week. She knows when a patient calls in, if there's a triage issue or something else, that she's really there to help kind of navigate them through the system. So we do infusions in our infusion room on the weekend, but it's primarily chemotherapy. We don't give cell infusions in the outpatient on the weekend. And then that's sort of the big pieces of our model of care, I think, operationally from a nursing perspective.
Colette, could you speak to the integration of research nursing to daily care in the clinic and how you are engaging with staff?
Yeah. So now that we have an actual dedicated immunotherapy clinic who provides most of the hands-on care for these patients, the research nurse's role is actually one of assisting in early education, patient care coordination, doing the facilitation between the actual infusion suite and the cell manufacturing facility, as well as being the lead liaison when the patient then transitions from an outpatient to an inpatient setting. The research nurse provides that continuity of care across the different care continuums. We partner with the nurses in the clinic in terms of patient assessments, adverse event assessments, compliance for protocol dictates and time points. Just being partners, friends.
BFFs is what I think they call you.
Yes, definitely.
You're the immunotherapy BFFs. In terms of the consent issue, both with commercial and research, why don't you, while you're speaking, Colette, speak to what the consent guidelines are around with clinical protocols, and then Karen, maybe you and Angela could speak to the consenting for commercial products.
So consents are institutionally review board reviewed and vetted for comprehensiveness and the right level of education preparedness for somebody to read and actually have informed consent. As Erin alluded to in the previous conversation, informed consent starts well before these patients actually arrive to our institution. It starts in the intake process where conversations are being had about what's required, what are going to be the responsibilities, what are going to be the burdens, what are the likely side effects, how long do these patients need to remain in the system. Informed consent is an ongoing continuum. We have several informed consent conferences, initially just to say we need to screen you for a particular target to determine if this is even a viable option for your therapy. We then proceed to talk about apheresis and consent to that actual procedure and a very focused clinical workup that these patients have to undergo. And then the last consent is that of, okay, we've done the workup, we've looked at you, we believe that this really is a viable treatment option. Do you want to proceed? And this is what it's going to look like. This is the therapy, this is how it's administered, these are the side effects that you may experience. Here's the commitment that we're asking of you and caregivers. Is this what you want to do?
Colette?
And for commercial, I didn't realize how easy I had it sometimes with just the clinical trials until commercial came into play, and it was sort of like, oh my gosh, what do? I have to make orders. I have to get a consent. I don't have all of those things that kind of came with the clinical trial package when commercial products came in to the clinic. So truthfully, my quick little gap analysis were those were the first two things that I needed built to actually get a clinical product into the clinic from a kind of a care perspective. Obviously, it is an enormous team that it took that you've already met throughout the rest of this topic. But those two things I thought, gosh, my nurses are not going to know what to do. The providers don't even know what to order. All of our ordering practices have been based around clinical trial support, so we're going to have to build something. So we quickly built infrastructure to say, we're going to have a cross-disciplinary group that's going to just create orders. And we did that for weeks solid. Multiple reviews, looking across the continuum of care, because we're across an inpatient and outpatient setting. We needed things that were going to cross inpatient and outpatient. If a patient got sick in the middle of lymphodepletion and they got admitted and they needed cells in the inpatient, we needed to have something that was going to cross across all of these settings. So there was a huge really bolus of work that we needed to do to get those things built very, very quickly. The other thing was consents, which brought me to this piece, this question, but I'd never written a consent before, and so I quickly dialed Stephanie May up, and who you met, and also we have a risk manager who helps with consent, building consents, and really tried to say, what do we need to have? What does the informed consent process look like for this product? And it's interesting in that you institutionally can kind of decide, is the sense that we got, what you would like to do. I know that the paper that Memorial Sloan Kettering just published about their starting of their program, they were very clear in that article that they feel like a consent is very necessary, and I felt the same for this therapy, and I think that institutionally that was also agreed upon. So we did develop a consent. And it was really a collaborative process. So I think that took time. You really need to be thoughtful. We needed to think about all of those things that she just mentioned that go into clinical trial consents. But we, how do we approach this from now an FDA-approved agent so that the patient is informed?
Angela, do you have anything to add to this process?
Thank you.
I was just going to add to that consent process that as we've created the consent and began that with commercial products, that you'll notice a consent for a commercial product is much thinner than that for a protocol and to be on a study. It really does not specify in the greatest detail as some of the research protocols every potential side effect. So there is a lot of the consent process that is more of an education. And so far, we have kind of taken our stance that as a patient comes in, we have a conference where we really discuss and explain the whole process, including all of the potential adverse events, and make sure they have a good understanding of that. And then almost come back after we've done their evaluation and said, yes, you're a candidate. Now, do you want to proceed? Do you want to sign this consent? So it's almost a two-step, even though there may not be a super number of days in between that, so that they can really understand after consulting with the experts on CAR T cells what those adverse events are before jumping in and signing that consent. Because as we've mentioned in the previous panel, sometimes that consent is what helps get it going as far as the insurance and requesting these cells. And that, again, is a financial burden as well. So there's a lot to think about on how quickly and how thoroughly you consent to the patient.
Thank you, Angela. And with picking up on what Keith talked about this morning, that consent is an ongoing process and the nurses are really at the bedside. Can you speak a little bit to the translation, the process of your nurses to your patients that they see over? How long would you say they're in the system from start to finish?
Probably about 2 months they're with us. So our nurses are amazing. End of story. Our nurses know about all of the treatments these patients are getting. And I think we all know that as our patients get comfortable in their bed or their chair, the real questions come out. And that's when the nurse gets to step in and answer the question. If appropriate, of course, some of the questions are, of course, outside of scope. But for the most part, that's when the nurse really gets that amazing time with the patient, that the patient says, I didn't really understand what CRS was, or whatever their question. So they come back to the nurses and they get to replay what they heard, and they get to actually get some quiet time to process the information and get it reinforced in a way that makes sense at a time that is meaningful to them. And I 100% feel our nurses are educated and given the time to be able to spend that time to be able to explain questions and anything else with the patient. So, yeah.
Thank you, Ann. I'd like to shift a little bit and look at documentation. So let's start with you, Lindsay, and talking about what are some of the documentation. You've talked about the job aid, but what are some of the documentation expectations for the immunotherapy program?
The documentation expectations are numerous, and it's a little terrifying to even consider. But that being said, with apheresis that has oversight with FDA, in fact, there's already a baseline large amount of documentation that's required, so we're already somewhat used to this. What's on top of that for a clinical trial is not significant. It usually comes more with the marketed products where we start to see a lot more documentation. And that's going to be, again, specific to the sponsor or the company's product. So for example, with a Dendreon product or with a Kite product, they have a web-based portal in which the staff have to all be trained. First of all, they all have to get their logins and their IDs, which is not an insignificant period of time to get everybody wrangled to get that. And then they all have to go through specific training on how to use the web portal. Then the portal itself will have a manual that goes with it that tells you how to enter all the information. And in addition to that, when the nurses are verifying the product before it gets shipped out, they have to find another nurse to do this verification step with them. And the person who's picking up the product to ship it, that person also has to do a verification step. So documentation could be 3 people deep at the same time. And that's just at that point in time. So then the challenge becomes, how do you get all of your staff trained and so that you have the greatest amount of agility to have operations continue every day of the week? How do you train a staff of 16 to all have access to those web portals? It's a little bit easier if it's not digital in terms of that challenge. So if it's just paper documentation, then you don't have to have a login to fill out a paper form, so that's a little bit easier. However, there's different documentation requirements. There's a different form for each marketed product. They will ask, some of them ask for more information and some ask for less, and this is true also for clinical trials. For example, the Juno collection form asks for a lot more information than does the form for the Novartis product. So there's going to be a little bit more challenge in terms of that documentation. There's always documentation error that occurs. We had a documentation error this week that seemed exceptionally trivial. However, we got pushback from the company to say, you need to error correct this. They already had the original document. We don't have the original document anymore. How do we retrieve the original document to do the error correction? So that's just the tip of the iceberg on that. And that's all on top of your standard documentation that you would normally use.
Thank you, Lindsay. Angela, do you want to speak a little bit to the process of documentation for providers?
I think in providers, it's very, I don't think there's quite as much nitty-gritty as Lindsay has to do. We're just documenting our standard notes for sure. Certainly, you want to document all of your education with the patients so that that is well mentioned. And then as we're evaluating the patients, especially after the CAR T-cell infusion, there's documentation of those adverse events and even just the symptoms that they're having. You want to be very clear what is put in so that as they may transition to an inpatient or come back to the outpatient, or even if you're just transitioning from providers, seeing them to have a good baseline that by reading the note, you understand what that patient is like and what they look like and what their standard blood pressures are, and are they, hypotensive on a different day? What is their neurological baseline? We have a wide range of normalcy out there, and so it's nice to kind of have a documentation for almost what is normal for some of the patients that you might think are not quite normal. And then the neurological checks that we do after CAR T cells are very important as well. And that is kind of variable on how we monitor that, but we have some protocols that actually mandate a full mini mental status exam be done on certain days. And I think we've taken aspects of that to do kind of on our daily checks with our patients. Orientation, obviously, alertness, just taking whether they're normal alert or if they're a little bit more somnolent or quiet. Those are easily things that might be missed, but it can be important, especially when you're looking at the beginning of neurological toxicity. We often, ask those questions about what day is it, and maybe even reminder of names or naming of objects. And certainly sometimes we can tell that patients are confused when they're talking to us, but if you can't, those are often ways to pick that up, as kind of the naming of objects and such. So documenting that in each note is particularly important.
Thank you. Did you want to say?
Some other things that we did a little bit more systematically when the clinic opened is that we tried to update our templates. So if we had provider templates or nursing templates for notes, we wanted to include those things that were specific to cell therapy that we thought were important for them to actually draw out. We wanted the charting documentation system to actually prompt people to think about what they should be asking. So those are things we did in the first couple of months. The other things that we did are we needed to update our documentation in terms of where we documented cell infusions. We had previously been documenting them kind of in our blood area, and then we realized with all of these new products that we needed to have a better way to be able to quickly go in and actually leverage our EMRs to be able to pull data. So we needed to create new fields and new names for things. So those are other things that you can think about leveraging for your EMR. I know some places have built in their actual, if they have a very formalized neuro assessment with scoring, they've actually built those things into their EMR. So there's a lot that you can actually leverage systematically to help.
Thank you. Did you want to say something?
May I offer some comments as well? Documentation, for those of you that do clinical trials, you know that documentation is critical to running a clinical trial, both from the beginning, documenting the elements of consent, to documenting eligibility, to documenting symptoms as they get better and get worse, utilizing templates, utilizing documentation guidelines or standards, educating our providers to the needs for review of comments on a daily basis, and not, copying and pasting, but actually asking the patient, specifically calling out symptoms and assessing whether or not that symptom exists. So documentation from the clinical trial standpoint is critical.
Thank you. I think that moves us really well into nursing assessment and some of the questions. How do you infuse the product, and what types of lines are acceptable to you, Anne?
We have a full gamut of how we infuse our T-cell products. So we have both fresh T-cell products as well as cryopreserved T-cell products with a varying percent of DMSO. So the majority of our cell infusions in the outpatient center are fresh infusions, which are given on a pump. And the commercialization of products came with gravity-based T-cell infusions, and the spread of what our nurses were presented with to have to administer from a fresh cell product on a pump to an IV push in a syringe to a gravity-based infusion, and the multitude of requirements and details that go into each infusion were quite significant. So our nurses are trained in a multitude of fashions. So when each product is coming in, they are trained on the treatment and the product. If it is a new cellular-based infusion, then we will do simulation-based training. And all of our nurses have to observe a T-cell infusion and then return demonstrate the infusion to ensure that they're competent in the skill set.
So let's.
And then the central lines that go with that is another important aspect. So our patients all require a central line to ensure that we can administer the product as well as manage cytokine release syndrome. So the type of line that the patients have, you have to take into consideration what did they come with, if anything, and then how will the product be infused. So a gravity-based infusion, we do not want to administer into a valved PICC line for the concern that it wouldn't free flow to gravity. So there's lots of discussions with our APPs to discuss what line would be best for each patient. So there's lots of considerations and clinical implications to the line that is chosen, and we work very closely with our APPs and medical team.
Yeah, I would just say that we have had success with every type of line in our immunotherapy clinic thus far. We have utilized Metaports, we have utilized double lumen Hickmans, we've utilized PICC lines. So almost any type of central line can be used to administer, but there is this kind of caveat for the gravity-based infusions, especially with the commercial products, that you do have to kind of steer away from those valved PICC lines. The patients being actively sick and recognizing that they have a potential for CRS, that is our main concern for wanting to have that central line in case they get sick. Following the CAR T cells quickly, ideally we would love for everyone to have 2 lumens. Sometimes we do with a single lumen Metaport, and generally our nursing staff has been great at managing that. But it's something to consider for each patient as they go through the process, what's really best for them, because certainly you don't want to put them through more procedures if you don't really have to, if you can manage with what you have.
And to support the infusion nurses with all of this variability in how we administer these different products, we do create standing orders which very clearly outline the product, the line that's required, how this product is to be infused, the documentation requirements after the infusion.
Thank you, Colette. In terms of lines in apheresis, do you want to speak to what kind of line assessments and procedures are in place for that?
Sure. In apheresis, there will always be a vascular access assessment done, and that's standard of care regardless of whether it's an IND, a marketed product, anything. And we are always aiming to do an apheresis collection using peripheral veins as often as possible, since that's the least invasive. For these immunotherapy products or for clinical trials, usually it's going to be a non-mobilized product, meaning that there won't be as much blood volume to be processed. So that's going to be a shorter procedure, which can typically be done using peripheral veins. Typically, if you're doing a stem cell collection, we might be processing 6 times your total blood volume, which could take up to 6 hours of total blood processing time. And nobody wants to sit in a bed with 2 arms immobilized and 2 steel needles in their arms that they can't bend for 6 hours. So luckily, with these smaller volume products, we can usually get away with peripheral vascular access. However, as I mentioned yesterday, a lot of times people don't show up with good veins, and then we're a little bit stuck here. We'd like to avoid putting in central lines as much as we can, and we've been fairly successful with that. Part of the consideration on that is knowing that downstream for an infusion, that's going to impact what line they may need to use as well. But luckily, any apheresis line that we put in that's suitable for apheresis can be used for infusion of the cells, so that's going to be okay. We're never going to be putting in a PICC line to collect cells through, so they're not going to be stuck later having this one point of access. It's a PICC line for an infusion.
So one of the competencies, just to keep on lines, because I like infusion, so sorry, bear with me. But we do a lot of temporary dialysis type lines for these collections. So one of the competencies that we've had to build into the outpatient nursing infrastructure is removal of those lines. So it's just something to think about. I know that there are sometimes limitations and restrictions in some settings about what lines they want DC'd in what location. So we do remove them in the outpatient department, and it's something that we train for.
Thank you, Karen. I'd like to move into AE reporting. There was questions from the audience of what to report and when to report. So let's start with clinical trials. Colette, do you want to take this first?
Sure. AE reporting is usually outlined within each clinical trial, and it varies based on the clinical trial, based on who the sponsor is for that trial. We have AE criteria, usually CTCAE, whatever version 4.03. AE assessment is starting actually with the clinicians providing the care. And then again, that need for very good documentation of the symptom. Does the symptom progress? Does the symptom get better? So that on the back end, dedicated either data coordinators or nurses or clinical coordinators can review those medical records and actually extract these symptoms, correlate them to an adverse event category, and then move them across the grading with start and stop dates.
Angela, do you have any comments on managing AEs clinically?
So I'm not personally involved in like the submitting of adverse events to FDA, et cetera, for these commercial products. But obviously, as a provider, we are managing the patients daily. We're documenting that in our note. Adverse events can be, the standard things you're normally used to with the chemotherapy, such as nausea and such, and managing that. And then following the CAR T-cell infusion, we're really looking at their vitals, their blood pressure. Are they having any orthostasis? Are they having orthostatic dizziness? Do we need to manage them with some IV fluids, either in the clinic or admission? Fevers are, of course, the biggest thing that we're looking for and that we educate our patients and caregivers on. Fever, luckily, is one of the hallmarks of CRS, and oftentimes is the very beginning. So recognizing when a patient has a fever and then managing that appropriately by admitting them to the hospital for close observation. Again, I've already spoken a bit about the neurological side effects. And then just the improvement as they, improve afterwards. Patients that, respond to therapy or the CRS just resolves are discharged from the hospital and come back to the outpatient, and they are weak and they are a little deconditioned and they're still recovering blood counts often. So just monitoring that very closely and kind of specifying that patient to patient, because it may vary. Some people come out looking and feeling pretty good and bouncing back very quickly, and then of course there are others that take much longer to recover. So just having to pay attention to how closely you need to monitor each particular patient.
Thank you.
So beyond identification and documentation of adverse events, there's also obviously the assessment and reporting requirements of adverse events. Adverse events of a low grade with low medical impact generally don't need to be reported in real time to either IRBs or sponsors or FDA. Those of a higher grade with a higher medical impact do. So having a dedicated staff that is monitoring patients daily to determine, is this an adverse event that is severe enough that requires us to do an expedite report, and then the attribution of that adverse event. Is this adverse event related to their medical condition? Is it related to our study intervention? And was this an expected adverse event? These are all elements that go into play as you're making an evaluation of those reporting requirements.
Thank you. And Karen and Ann, I'd like you to comment on with the commercial products and this transition into implementation with our products being so new, how are adverse events tracked and reported to the company as well as to whom do they go?
So Carrie spoke to this, I think, in the last panel, that the decision that we made is that this kind of goes through our quality department. So we basically provide the care to patients, and we document thoroughly as we would for any other patient. But the actual reporting is not done by members of the clinic and is done through our quality department.
Thank you. I think there's one question I want to ask. I think, Lindsay, you answered this yesterday. It was from the audience. Can you give blood products before, during CAR T-cell apheresis?
Yes, if it's clinically necessary for the patient to receive blood products, then they should absolutely get those, regardless of what collection is going to occur. And I think that that is something that clinical trial, marketed product clinical trial designers don't often have a lot of understanding about. I think that that's something that they need a little bit more education on, not because it's going to impact the product, but that's what they don't often understand. So they'll be alarmed if they find that the patient received a blood product transfusion just prior to collection, and they'll wonder, will that have an adverse impact on the collection? And it's our job to kind of help them over that hump and say, no, this is standard of care. It will not impact the product. In fact, they need to have that blood transfusion or that platelet transfusion in order for them to safely undergo the apheresis procedure.
Anybody else want to add anything? The next area that is, I think, key to address is what Keith brought up, which was the idea of how do you support the family, the patient and the family with basically the needs of severe illness, change of employment, all of those things. So how are the patient and the caregiver offered support? And actually, Karen, why don't you start with how the team is designed and who's integral to that process, even in the team room?
So it starts with intake, and you met Erin on the last panel. So she is actively coordinating, calling patients, family members. They are also interacting with our patient finance department that is really trying to help the patient understand what is the actual detail of their particular plan. So we have those two places that that support's offered really from the time, even before the patient arrives to the clinic. The other thing that our intake department does is also really try to get into conversations with patients about the housing resources that we have available, shuttles, other things that they need to plan for, giving them the upfront information about caregivers, things like that. So, so we've really tried to have that be an informational piece that's offered very, very early. Then when they arrive to the clinic, we always have them meet the provider on the first day, and then we have them meet with a nurse, and we essentially have sort of a 1 hour get to know you orientation to the clinic, and an assessment of what the patient has going on with them. They meet with a social worker within the first 3 days of arrival to the clinic, so that's kind of a planned meeting for every single patient so that they can also do assessments of distress screening and all other sorts of things that, that they may need to be able to support the patient through. So we try to do a very personalized approach, but we set up the infrastructure so that these meetings are planned to happen, and that we can get them really quickly into the other support systems that we have. Because we are a comprehensive cancer center, we do have all of a wide variety of other supportive services. So we certainly refer patients to chaplaincy. We have palliative care available. We have pain management services. We have all other sorts of kind of supportive care that we can bring in, and those tend to be based on a patient-needed basis.
The other thing that we have is our clinical team, as well as the research team and the pharmacist and social worker and the nurses, all have rounds 3 times a week. So the social worker is also abreast of concerns that are ongoing or upcoming for the patients. So that's another way that they are integrally involved, and sometimes they're the first ones to say, I see what's coming, and be able to anticipate those needs, which is really priceless to have them involved with that.
I want to invite people to, are there questions in the audience? Anybody have things they'd like to ask? We have our front row Montefiore team here, come on up. we need you to speak in the microphone only because we're recording this, and when people listen, they need your voice.
One of my concerns is that a lot of the talk is about what you're doing, and it seems to be about yourselves. How are you finding it with the commercial products? Because that's where most of us are moving towards, because we don't have your infrastructure to support all the research that you're doing here.
We are doing commercial agents. We have Yescarta. So actually what we found is that much of the high level infrastructure that we had put in place for the clinical trials, we were actually able to adapt to these. So the same scheduling essentially sort of applies. I mean, we still see the patient on the first day, they meet with a social worker. We do admit them for their actual infusion of Yescarta. We have transition nurses in our program who actually do the discharge planning across BMT and immunotherapy to the outpatient department. So they come across both settings, so they really understand outpatient, they understand inpatient, and they're really that key communication conduit to ensure that we have things scheduled and in place when the patient discharges, and that we also have appointments and other things that somebody is really telling the patient before they leave what to expect when they leave the hospital. So I think that there are definitely similarities that we see across the clinical trials and in the commercial agents, and what we're trying to do, and I think Liz appreciated this even a little bit yesterday, is standardize as much as we can. I mean, the more variety and the more boutique approach we take to all of these things, the harder it gets. So as much as possible, we really try to put things through this kind of flow that we've developed where we typically do these things in the outpatient. We have these players that we know are going to support the patient at these particular time points. And then we kind of move them along the system in that way. Does that answer your question? Because if you've got other additional questions, I'm happy to elaborate. But I found that it's pretty similar.
I'd like to elaborate and to your question. The unsung heroes that actually are not well represented for SCCA here in this room is our cellular therapeutics quality department. I would be back at home trying to spell immunotherapy if we did not have this crew of people, and it's a large department. They were exceptionally instrumental in helping us launch our marketed products because they were there every step of the way orchestrating when the pre-study visit came through, when the site initiation visit came through all of the auditing. I barely have to lift a finger for that. I have to be present for it and answer all the questions, but they get everything set up for it. So without that quality infrastructure, it will be very difficult to bring a marketed product in the door.
Hi, I work at Seattle Children's on the inpatient unit, and we get our patients on the inpatient setting for a small but very intense stay. And so I wondered if you could speak to your standards on communication and education with inpatient and particularly ICU nurses so that they have what they need to take care of these patients in the inpatient setting.
Thank you. And I know there's some UW nurses here in the audience, so I may ask them to come up if I get stuck. But we really work comprehensively across the program. So the inpatient nurse managers, truthfully, they're part of looking at the clinical trials. So they're part of the review process. They've been part of our planning for implementation from the very beginning. So what they're actively doing is really looking at where are their nurses expected to be the primary caregivers on particular trials or particular agents, and how do they need to educate their staff. In general, I think we've taken the approach that we have enough clinical trials and enough commercial agents that basically anybody working in oncology really on those units needs to know what CRS and neurotoxicity are. So those things we've approached by kind of going to education days, offering educational offerings. Our CNS actually goes across our inpatient and outpatient setting across BMT and immunotherapy, so she's really an important conduit to kind of see what this looks like for nursing care and practice across both settings. So she's key. So we train for infusion, and they really we help them, we include them in the process if we've got a new infusion that's going to be administered inpatient. We really work together to help them establish training plans. I mean, it's a team effort on all of these things. For ICU, I think what we've really had to do, and our medical directors have gone to ICU, our CNS has gone to ICU, our REMS coordinator has gone to ICU to train them. We are lucky and privileged enough that we actually have a medical oncology ICU, so we actually have a group that is seeing the oncology ICU patients. So they are now starting to see more of these patients, so certainly with more patients, they start to understand a little bit better. I think what they've really needed in terms of toxicity management is the idea that these toxicities are actually not unexpected, because oftentimes when you see oncology patients in the ICU, they're like, this is not a good situation. We're not sure if this patient's going to come out of the ICU. And in this situation, these things we can often manage patients through, and we in most instances, we are expecting that patient to walk out of the ICU after their pressors and their CRS or neurotoxicity resolve. So they've needed, I think, validation from medical providers to have them understand what is this, just like these sorts of conversations. What are CRS? What are neurotoxicity? What is the trajectory of this? We've had order sets that we've created that actually are created specifically for the management of neurotoxicity that have a lot of their care built into them. And so they have more familiarity with that, with the more infrastructure that we put in. But it's needed some time, some face time with them to have them kind of understand what this is, because they're starting to see more and more of it.
I think one of the other things that we provide for our inpatient care Education, that's first and foremost. Resources and tools, what are the guidelines for how you manage CRS? And then consultants. All of our patients have access to the immunotherapy attending as a consultant, ICU or floor.
More questions?
About like the post transfusion, post CAR T cell follow up. Do you have like a guideline for when you check for the B cell aplasia? Do you send any flows for that, and how often do you do that?
So we are still kind of in the process of figuring what our standard for this post care is. However, at this time, we are kind of evaluating IgG levels as well as B cell kind of reconstitution at approximately day 28-30 when we're restaging. That's right now just kind of information that we're adding, and we don't always know what to do with that. But we certainly, as we send patients back to their referring oncologist, we explain to them that CD19 CAR T cells may, cause long-lasting B-cell aplasia, and that IgG levels need to be monitored every 1 to 2 months. Our institutional recommendations are to replete with IVIG if your IgG levels less than 400. Sometimes you can see them starting out very low from the very beginning, just because these are very heavily pretreated patients often. But that is certainly a potential long-term side effect that should be evaluated. Whether you're actually looking for the recovery of B cells and what to do with that is still a little up in the air. We kind of utilize it as sometimes looking to see if there's B cells just as a way of maybe knowing whether the CAR T cells are still persistent, but that's not an exact science really at this time. It is certainly something that we do on occasion and then try to maybe make some sense out of it. But really, you have to kind of see the picture as a whole and just these little bits of information. And I think as time goes on, we might be able to, have some research looking at that more specifically so that we can make sense out of it.
So all of our clinical trials have very clear dictates for time points with which we do monitor B-cell recovery. And we do that on an ongoing basis. It doesn't necessarily direct clinical care at this time point, but it's going to be through that accumulation of data and then the determination of what was the clinical experience of the patient that we will ultimately be able to influence a standard of care.
Until we have at least one more question.
Is there a limited time window that exists for the patients to receive their new CAR T cells between receiving the lymphodepleting chemotherapy and if they get sick? I mean, we've had patients admitted after getting the flu-cy, coming in patient to get them in better shape, and their cell day is delayed. So I'm just wondering what that looks like for patients. What is the threshold? How sick can they be to get the cells? If it's delayed and already been processed from the manufacturer, have you ever had an instance where patients haven't gotten their cells? Are they then responsible for paying and storing the cells? I mean, are we refrigerating them? Do they have to be cryopreserved after this? Sorry, it's kind of a lot of questions, but just curious.
I'll try to speak to some of that. We have been fortunate enough thus far not to have any of our commercial patients not receive their cells. There has been a delay at least once, and then with our protocols, we've had multiple delays in the past because of similar situations. The patients become sick or another adverse event, maybe their liver tests are markedly elevated or creatinine, something that you want to work up and evaluate before giving them the potential cells, which may potentially cause CRS and additional organ toxicity. At this point in time, our kind of standard is that we can delay the cells up to 7 days from lymphodepleting chemotherapy, and then we decide
if they're able to receive it, that would be great. And if we can't at that time, then we need to make a consideration of waiting and potentially repeating lymphodepleting chemotherapy when they are better. So that's kind of what we're doing ourselves. And then that question of when is it okay to give, like how sick can they be, that is really, we've been specific on, if they have an uncontrolled active infection. It's kind of our terminology in most of our protocols, and we've moved that as well to kind of our institutional standards with commercial products as well. Then we try to delay the cell infusion. If we feel like toxicity that we're seeing is because of tumor lysis or because of disease, then we have to make a medical decision whether to proceed or not. And it's a little bit different on every patient.
And you can follow up more lately, because that's a whole dissertation ahead of you there. This will be our last question.
Hi. So the issue we're having in setting up our clinic at Stanford has been sort of how do you set up your clinic templates? Because let's say you have a provider, and so the initial consult, how long is that visit? Who sees the patient? Because what we've run into is that these new patient visits turn into 3-hour visits between the fellow, the physician, social work, nursing. And so we can't defend, I guess, the billing part of it to the clinic space. And so I just wanted to get a little bit info from you guys.
So I think I can speak to that because that was certainly my life for probably the first 6 months of opening the clinic. It was like, oh my gosh, what is an Epic template? I have no idea. What we did is we tried to translate. I mean, we had to do something. We had to move forward with our best foot, right, in terms of what we thought the time would take for things. And then we actually just did a lot of refinement. So we did data collection in terms of how long the actual visits are. And I think, the visits are as long as you need them to be. And then, you have to look at how much time do your providers have available. Is there potential for you to maybe parse out pieces of it in a different way with a different member of the care team? Really, you get the ability to design whatever you want. We do have consults available, so those consults are typically done with an attending provider. The times for those, I think, are generally about 90 minutes to 2 hours. But we've looked at, do we even need to kind of develop a new model where we have something where the EPP is doing a piece of that and then the attending comes in after that. So those are all questions, truthfully, that we are really just, as we look at our care needs, we're developing and trying them on and then readjusting the times on the templates based on what works best. So I think it sounds like you're trying to do exactly what we've done and you just refine that over time.
So I'm going to have to close the questions and giving you time to have Dr. McDonald come up and give the closing comments. But what I want to remind you all of is that this is the beginning of dialogue, and what we need to have are these kinds of discussions across the country. This is not something we should safeguard as intellectual property. We need to protect this as shared clinical best practices and best outcomes for the patients that we care for. So let's give the panelists a round of applause.